Hi, this is Dr. Shinjini and I welcome you to the part 2 of the lecture series, rather the lockdown lecture series. And our today's continuation topic is rectum, a discussion on peritoneum, mesentery, mesorectum, the fascial anatomy in relationship to disease and surgery. So one of the greatest truths in life is that nothing in life is constant except change. And just in the way that we grew up using these old tungsten filament bulbs, and now we have easily accepted these CFL bulbs, which are better in technology in terms of saving energy, light, etc. In a similar manner, science, especially anatomy, surgery, medicine, is rapidly changing by the day. And it is wise for any clinician, doctor, surgeon, etc. to learn his field with regards to the rapidly changing knowledge. It is also very important in our field of medicine and surgery, especially because in our particular field, there is very little or actually no margin for error. And I quote Warren Buffett. He said, "Bad terminology is the enemy of good thinking." So herein we start our journey to learn the mesentery, the peritoneum, the relationships pertaining to disease as well as surgery, understanding these concepts using the right words. And whenever we use the right words to understand any science, we automatically understand the science in its best manner. So before we start on the lecture proper, let me tell you that some of the next facts and slides may be just a simple revision for many of you. However, I do feel that for the completion of the topic and to get a proper orientation of the entire abdominopelvic cavity, we need to discuss these topics. You may, however, skip these slides on the timeline and proceed further if you feel that this is just a mere repetition. Now I want you to focus with attention onto the photograph in front of you now. See the right part of the photograph and see that balloon into which that fist is indenting. So basically you have to imagine a very elastic or a very stretchable, completely enclosed balloon. So this balloon basically becomes our peritoneal cavity. So the peritoneal cavity is actually nothing but a mesothelial cell layer lined balloon or space which contains some amount of physiological fluid which is secreted by the mesothelial cells, about 50 ml or so. And this balloon is large, elastic or very plastic in its nature. Now just as this fist is indenting into the balloon, if I ask anyone the question, is the hand or the fist inside the balloon? The obvious answer will be no. The fist is not inside the balloon. The fist is indenting into the balloon or invaginating into the balloon, but the balloon containing air/fluid, anything, is an intact cavity by itself. So basically, peritoneum, the word peritoneum arises from a Greek word which means to stretch. And herein lies the beauty of this word. The stretch element is so important that you have to imagine something like an enclosed double layer plastic bag which is extremely elastic or plastic in its nature and into which the gut system invaginates in its period of embryonic growth and development. So again, coming to a repetition of the first fact, the peritoneum is an enclosed cavity. There is nothing so-called intraperitoneal. The intraperitoneal word is basically a misnomer. We will see how the word intraperitoneal is a misnomer. The peritoneal cavity does not in actuality contain any content. And this is the most important part that we need to understand and remember. Now, just imagine that this fist which is in the balloon pushes into this balloon so much so that two folds of the inside of the balloon are snugly lining the fist. In a similar manner, when the bowel grows into the peritoneal cavity to various degrees in its stages of development, we have the different type of organs or the viscera of the gut and the abdominopelvic cavity investing into the peritoneum by different degrees. According to the invagination or investment into this peritoneal cavity, the peritoneal cavity can be said to line the entire abdominopelvic region, some organs completely, almost completely rather, and some organs partially. And on the basis of this invagination and consequent lining with the peritoneum, organs may be divided as intraperitoneal or retroperitoneal. The retroperitoneal organs are divided divided into peritoneal and primarily retroperitoneal, and we will see how this terminology takes place. So now you can see from this beautifully depicted diagram how an organ becomes so-called intraperitoneal. So if you look at the first part of this picture, you will see that the bowel loop, as it grows in the early embryo, starts indenting or invaginating into the peritoneum. As it moves further inwards, as a consequence of its growth, the peritoneum gets stretched on it from all around. And if you can see the third picture in this larger picture, you will see and realize how the peritoneum gets invested and then returns back to get reflected onto the outer surface. So now the peritoneum, which is almost covering the bowel, forms the visceral peritoneum, and the two leaves of the peritoneum which get reflected back towards the abdominal wall form the mesentery. So what is mesentery? Mesentery is basically two leaves of the peritoneum which get reflected back from the organ itself onto the abdominal wall, and the outer one is the parietal peritoneum. So from this diagram, it is very easy to realize the three parts of the peritoneum. The outer one, which is known as the parietal peritoneum and which will be lining the abdominal wall. The part of the peritoneum in contact with the bowel, which is the visceral peritoneum, and the double layered membrane which kind of reflects back is the mesentery. It is this mesentery through which the entire blood supply, the lymphatic supply, and the nerves enter from the posterior abdominal wall into the organ. Now you must always remember that the visceral peritoneum, or the part of the peritoneum which is covering the bowel loop almost completely in the case of an intraperitoneal bowel, will form the final most layer of the bowel wall. That is, the serosa of the bowel is actually nothing but this visceral peritoneum. So, serosa of an intraperitoneal or the mesentery, but the visceral peritoneum, and is actually continuous with the parietal peritoneum. Now this diagram is a still better depiction of what was told in the last slide. You can actually see is the middle part. So in Greek, the word mesentery means middle, and we can easily understand from this diagram why it is called middle. Basically, it's a part of the same balloon, but it is the middle part of the balloon into which an organ is invaginated or suspended. So if you can see now from this picture, the part of the balloon or the peritoneum which is in contact with the bowel is the visceral peritoneum. The outer part is the parietal peritoneum, and the part which is in the middle through which the vessels are moving, the nerves, the lymphatic network also moves in, and which also contains a significant amount of fat. This part is that double layer of peritoneum which reflects from the organ towards the posterior abdominal wall. So the mesentery is a double layered peritoneal membrane which suspends the organs into the abdominal cavity and keeps them in position throughout life. If it weren't for this mesentery, most of the abdominal organs or the gut abdominal organs would drop into the pelvis. So the mesentery plays a very, very important role. Apart from its many other functions, one of the main role is to support the gut system and to keep the long, almost 6 meters of gut inside in place in a compact manner. What is not shown here is that the mesentery contains a large amount of fat as one of its contents, and which we will see later on. So now this figure clearly illustrates on how a secondary retroperitoneal organ is developed. If you see this figure, you will realize that secondary retroperitoneal organs are those organs which develop initially during embryonic development as intraperitoneal. That is, they have a mesentery, a dorsal mesentery, which suspends them initially. However, as during development, there is a complex rotation of the gut and also readjustment of the organs back into the abdominopelvic space to get back to the adult configuration. These organs, in this process of rotation and moving back into the abdominal cavity, what happens actually is that their mesentery gets reapplied back onto the parietal peritoneum of the posterior abdominal wall and gets adherent back to the parietal peritoneum. So if we have a look at these organs, we will feel that they are retroperitoneal. However, They started off as intraperitoneal with their mesentery getting adherent back to the parietal peritoneum. So if the peritoneal cavity is opened during surgery, these organs will appear as retroperitoneal. However, since they started off with a mesentery which is just applied to the posterior peritoneum, these organs will have an easily identifiable and developable cleavage surgical plane. So, when a surgery on these organs is required or it is required to mobilize these organs for any surgery, the surgeon can always use this embryological fact, and actually in any surgery it is these planes that are developed. So let's look at the extraperitoneal organ in the next slide, and you will now realize that the extraperitoneal organ just sits on the posterior abdominal wall. It just has the peritoneum which moves on top of it. It does not invest into it, and one of the most important examples is the kidney. In order to approach the retroperitoneal or an extraperitoneal organ, you have to cut through the parietal peritoneum to reach it, or you may move in a completely extraperitoneal approach also. Now, from these three diagrams, it is easy to understand that peritoneum is very vital to surgery. Its understanding is very vital to surgery. Organs which on opening the peritoneal cavity appear very mobile are generally intraperitoneal, and the three classical examples of intraperitoneal organs are the ileum, the transverse colon, and the sigmoid colon. So again, elaborating on the same approach, we will see that totally retroperitoneal organs, for instance, like the kidney, if we do a laparotomy or if we open the peritoneal cavity, we will really not be able to look at them like how we would probably look at the ileum, the ascending colon, the descending colon, etc. We may be able to appreciate the bulge of the kidney in its position. However, looking at it is not possible. Such organs are therefore retroperitoneal. So till now, we have basically learned three things. One, that the peritoneum does not have any actual content except some amount of physiological fluid. In performing a laparotomy or even a laparoscopy, we actually see organs through this balloon. That is, we poke the balloon and enter into it and then look at it. And the most important thing, we have realized that organs are classified as intraperitoneal, secondary retroperitoneal, or proper retroperitoneal, and because of this we have the various approaches to surgery. So I now want you to imagine and understand one very simple thing which we do often when we perform any laparotomy, that is when we open the peritoneal cavity, but we never tend to think about it. So when we open the peritoneal cavity in any open surgery, and when we look at the organs like the ileum, the transverse colon, or the sigmoid colon, these organs appear to us as very mobile. In fact, we can actually lift them out with our hands, and if we pull them or lift them, it is very easy to have a look at their dorsal mesentery, and therefore these organs are intraperitoneal. Their mesenteries sometimes are given very specific names. For example, the mesentery of the transverse colon is the transverse mesocolon, the mesentery of the sigmoid colon is the sigmoid mesocolon, and the mesentery of the ileum is sometimes called as the radix mesentery or plain mesentery. However, when we do a surgery or a laparotomy and we look at organs like the ascending colon, the descending colon, or the duodenum, we realize that we cannot really lift them out as we would be able to lift out the ileum, for example. And these organs are therefore secondary retroperitoneal organs. They are visible to us in any surgery. However, they are not very mobile. In order to make them mobile, however, we can easily develop the surgical cleavage plane, that is the colofacial plane in the case of the ascending and the descending colon. And when these organs are mobilized, their mesentery can be actually seen. And this concept of mobilization of the entire colon is utilized during total colic resection for colon cancer, also known as total mesocolic resection. In fact, a better word is total mesocolic resection. So, although the surgeons have been performing these procedures of mobilization of the entire colon for years, and therefore the mobilization of their mesenteries. This fact that the mesentery is a continuous organ from the start of the mesentery of the jejuno-ileal junction to the rectum is a fact that not many people realize. We will discuss this a little more in detail after a few slides. Right now, it is just enough to remember this. So now let us look at this very common picture that we used to study in our textbooks during the anatomy classes in olden days. And this is a sagittal section of the female body, and now it is so easy and clear to understand the concept of the peritoneum. The black line which is investing a large part of the abdominopelvic organs is that one stretchable big balloon of the peritoneum. The part of the black line which is against the anterior abdominal wall or the posterior abdominal wall is the parietal peritoneum. That part which lines the viscera to various degrees is the visceral peritoneum, and those double layered folds which are suspending these organs against the dorsum or the posterior is the mesentery. Now, the double layer of the mesentery allows the movement of the vessels, the networks and the nerves to enter and feed these organs. You must remember that the same peritoneum has different layers and folds which are given different names. As we already saw, we call it as the mesosigmoid, the transverse mesocolon, the mesentery for the ileum, the mesogastrium sometimes. Similarly, sometimes peritoneal folds are also known as ligaments. A common example is the falciform ligament. That part of the greater omentum which is seen between the stomach cross section and the transverse colon cross section is sometimes known as the gastrocolic ligament. So sometimes peritoneal folds are given the nomenclature of ligaments, and similarly the greater omentum here is nothing but folded peritoneum, and it is now so easy to understand the formation or the structure of the greater omentum. If you just follow this diagram, you will very easily conceptualize that the peritoneum gets reflected off from the visceral aspect of the stomach, and instead of just reflecting off immediately, it kind of overgrows into something like an apron, and these two folds of peritoneum from the visceral surface of the stomach grow and go down, and then it folds back to come up and invest on to the visceral aspect of the transverse colon. Again, it covers the transverse colon and then is reflected back to the posterior abdominal wall by a double layer transverse mesocolon. So sometimes we were taught that therefore the omentum has 4 layers initially. Similarly, you can also appreciate the double layered lesser omentum between the large liver and the stomach there. This is basically an oversimplified view. However, at this juncture, it is enough to understand this. And so I just love this cute diagram here, which actually depicts the concept of the peritoneum so well. And as you can see that this dog, which is made up of the same balloon, has parts which are named differently. In a similar manner, we just discussed how the same folds of the same balloon of the peritoneum is given different names at different places. So just like the caudal part is named as the tail, we name the peritoneum somewhere with some nomenclature. So there are different parts, but they are all made up of the same balloon. Now if you look at this figure shows the embryo in its early stages of development, and you will realize that some organs have a ventral mesentery as well. That is, they are suspended by the folds of peritoneum anteriorly as well as posteriorly. However, if you notice, the major part of the gut tube, that is the midgut and the hindgut, has mostly a dorsal mesentery. It is only the foregut, that is the stomach and the liver, which have some parts of the ventral mesentery. So the dorsal mesentery is basically continuous from top to bottom. This is an important point to consider. You will see that the vessels supplying the gut tube from the foregut, midgut to the hindgut enter from behind, from the aortic axis, pass through the mesentery, to supply the various parts of the gut. So, on top we see the celiac artery supplying the foregut. In the middle, we see the midgut, which is getting supplied by the superior mesenteric artery, and the hindgut, which is being supplied by the inferior mesenteric artery. Now, here in embryology, it is important to remember one fact, that if you see the development of the hindgut, just because we are talking on the rectum, we find that the middle 1/3 or the distal 1/3, both middle as well as distal 1/3 of the rectum, develop from a structure called as the cloacae. Now, this cloacae is actually supplied by branches of the anterior division of the internal iliac artery. Therefore, the rectum has a triple blood supply. One, the inferior mesenteric, because it shares a part of the dorsal mesentery of the hindgut. Two, from the anterior division of the internal iliac in the form of middle rectal artery. Three, again the continuation of the anterior division of the internal iliac artery, the inferior rectal artery, which is a branch of the internal pudendal artery. So, the triple blood supply is because of this, let us say, a curious embryological origin of the rectum. Again, if you concentrate on this particular figure, you will find that the midgut is getting looped out of the abdominal part of the embryo here and is getting tugged towards the umbilical cord. Now, this event of herniation of the midgut takes place at around the 5th week of the fetal development. Basically, what happens is that the midgut components, which is the jejunum, ileum, appendix, cecum, ascending colon, hepatic flexure, and the proximal 2/3 of the transverse colon. These are the derivatives of the midgut. So, these structures kind of develop very, very fast, and the gut tube elongates at the level of the midgut very rapidly. This cannot be taken care by a relatively slowly growing abdominal wall. So, in order to accommodate for this rapid growth of the midgut kind of herniates into the umbilical cord in and around the 5th week of embryonic life. This is known as the physiological herniation. Now, this herniation or the physiological herniation takes place dragging the peritoneum or the dorsal mesentery along itself into the umbilical cord. This herniation also therefore drags the superior mesenteric artery supplying the midgut, and once this herniation happens, the loop of the midgut that is pulled towards the umbilical cord can be thought of into two segments, the cranial limb and the caudal limb. And after this herniation, there is a complex procedure of gut rotation and then getting back into the the abdominal cavity, and this is complete by the 10th week of embryonic life. So, this entire process of herniation, rotation about the axis of the superior mesenteric artery, and consequently rotating the dorsal mesentery or the folds of the peritoneum along with it, leads to the final configuration that we see in the adult. Now, if this is not clear at this stage, we will describe this in the next 3 slides. So, in order to understand what was said in the last slide better, let us look at this model of the embryo, and here you will see that the embryo's back wall is seen behind. You can actually see faintly the aorta dividing into its 2 common iliac arteries. So, that's the posterior wall. The side door, which is open and is lined by the cling film or the plastic, is the lateral abdominal wall, and you can see the midgut, which is extended out towards a hypothetical umbilical artery, depicting the so-called physiological herniation. You can see how the midgut has elongated very, very rapidly. It has also, in this elongation, stretched the peritoneum, which is enveloping it and therefore stretching its mesentery also. You can see the ramification of the superior mesenteric artery along the mid part of this mesentery, and this looping out of the midgut therefore has an upper limb, which is known as the cranial limb, and a lower limb, which is known as the caudal limb. Remember, the upper or the cranial limb will form the ileum or the major part of the jejunum and the ileum, while a small part of the ileum, that is the distal ileum, appendix, cecum, ascending colon, hepatic flexure, and 2/3 of the transverse colon will be formed by the lower limb or the caudal limb. Now, as you can see that the hand which is pulling this loop is dragging it towards the front or towards the umbilical cord. Now, imagine that this extended loop undergoes a rotation in a counterclockwise manner facing the embryo. So if we are standing in front of the embryo and we are facing the embryo, then from that perspective, this loop which has herniated into the umbilical cord will rotate in a counterclockwise manner. So the first 90 degree of rotation will take the cranial limb of the midgut in a position such that it now points towards the right side of the embryo or towards the left side of the observer who is standing in front of the embryo. So let us speak everything from an embryonic perspective. So now after the first 90 degree of rotation, the cranial limb is now to the right of the embryo. Remember, the cranial limb is going to form the ileum. After this 90 degrees of rotation, there is yet another 180 degrees of rotation in such a manner that the entire peritoneum, that is the mesentery, also gets turned around this axis. So in totality, 90, 90 and a third time 90 amounts to 270 degrees of rotation about the superior mesenteric artery pedicle, taking the turns of the peritoneum or the mesentery along with it. And in this manner of this complex rotation, this ends with the adult configuration leading to the caudal limb coming on top of the cranial limb. So this is how the rotation proceeds. You can actually see that now the second 90 degree, that is 180 degree of rotation is complete, and another 90 will now give you the third picture as I am showing to you now, and you can see that the caudal limb is actually on top of the cranial limb, and this caudal limb gives us the adult configuration of the so-called ascending colon, transverse colon, descending colon, forming a picture frame like structure into which compactly situated is the ileal structure. Now, because of this complex rotation, you can see how the mesentery has got multiple times folded. That is why we get the configuration of the mesentery of the ileum. Now the ileum is situated to the left part of the fetal abdomen, and the mesentery, because of this folding, has a certain root. The mesenteric root, therefore, for the ileum, when we are describing its surface marking, is then said to be at the level of L2 vertebra onto the left side of the L2 vertebra, and the end of the mesenteric root is on the right sacroiliac joint. So the root of the mesentery, as you can observe from this photograph, is the bony landmarks are L2 vertebra level to the left side of the midline, extending diagonally across towards the right sacroiliac joint. This has been depicted by the green color in this diagram. This photograph again illustrates the concept of continuation of the mesentery as a continuous organ from the jejunal-ileal area to the rectum, and you can see how the fat of the mesentery is continuous all along. If you see the right side of this picture, you will see the ileal mesentery in particular, and although the entire mesentery is one continuous organ and the mesentery is not fragmented, this is the latest concept, but this picture will illustrate the ileal mesentery as a diagonal line, and the ileal loops therefore preferentially lie on the left side of the abdomen. So basically this slide I have just added to reiterate, as I have told previously, that when we take the cross section or the cut section of any visceral organ, then the outermost layer, or what is known as the serosa, which is marked by the yellow color there, is actually nothing but the investing layer of the visceral peritoneum. So in histology, when we say the various layers are the mucosa, submucosa, the muscularis and the outside serosa, we should immediately understand that the serosa is actually that part of the balloon which is hugging onto the organ from its outer aspect. Now coming quickly to the embryology of the peritoneum and therefore the peritoneal cavity. We cannot really discuss the embryology in depth since this is a vast topic by itself. But if you still remember a little bit of your embryology, and to put it very simply, I will tell you that in the third and the fourth week of intraembryonic life, the embryo is defined as trilaminar. That is, it has three layers, as you can see on the left side of the photograph: the blue colored ectoderm, the middle mesoderm and the yellow endoderm. So this embryo is known as a tri-layered embryo. Now the middle layer is the one which is of importance, the mesoderm layer, and this is the one which helps to contribute to form the peritoneal cavity and also the two parts of the peritoneum, the parietal and the visceral. Now if you see the middle mesoderm and go to the lateral part of this mesoderm, so this lateral part of the mesoderm is responsible for formation of the peritoneum as well as the peritoneal cavity. So the tissue or the cells in the lateral plate mesoderm split, forming a space which is known as the coelom, and the top layer, which is the somatic layer of the peritoneum, goes about to form the parietal peritoneum, while the splanchnic limb goes to form the visceral peritoneum. The space, which is that small white area marked as the coelom, will later on develop into the intraembryonic coelomic cavity, and in the adult this will correspond to the peritoneal cavity. You can see a better view of this on the right side of the diagram, wherein the coelomic cavity is clearly demarcated and the two blue structures on the outer and the inner side are respectively that part of the lateral plate mesoderm on the outside, the parietal one, and towards the inside, the splanchnic one. Notice that the inner or the splanchnic mesoderm is lined by the yellow colored endoderm. So together during the formation, these form the bowel wall, that is the endoderm forming the mucosa and the outer layers being formed by the splanchnic mesoderm. So now coming to our familiar gynecology, and if you notice this figure, you will notice that the left side is the female in pink, the right side is the male in blue. If you notice their peritoneal sacs, there is one major difference between the peritoneal sac of the female versus the male. The male's peritoneal cavity is a completely enclosed balloon with no opening at all. And this is the beauty of nature. The peritoneal cavity in the case of female has two small 1 millimeter openings, and these are the openings where of the fallopian tubes into the inside of the peritoneal cavity. So basically the female peritoneal cavity communicates with the external environment through the opening of the fallopian tube. So now look at this slide and pay attention to what happens during ovulation. See how charismatic nature is, and whenever there is an ovulation, the ovarian surface epithelium breaks open, as we all know, and the ovum is actually released into the peritoneal cavity. This is then taken up by the opened end of the fallopian tube, which, as I told you previously, is a 1 millimeter small opening into the peritoneal cavity and then moves inwards into the tubal lumen. So now please pay attention to this image in front of you now. Basically this shows the genital organs covered by the visceral peritoneum. The visceral peritoneum here is marked in sea green, and you can see, if you focus on the bottom of the image, on how the peritoneum gets reflected off. Now if you see the ovary marked on this image, you will see that the same investing layer of peritoneum covers the ovary also. Strictly speaking, this is not very true. The outermost layer of the ovary, which is also known most correctly as the surface epithelium of the ovary, is actually made up of a single layer of cuboidal cells. We all know from previous discussion that the peritoneal cells or the cells of the peritoneal layers are mesothelial and therefore flat cells. So there is a lot of debate on whether the peritoneum of the ovary or the covering of the ovary is the same as the visceral peritoneum of the other surrounding organs. This happens to be a matter of lot of research also. Now, why is it that the surface epithelium of the ovary changes its character? It has been found that probably this is due to the influence of the steroidal hormones that the gonad secretes. So, when the embryonic gonad secretes steroids, this may cause a certain change in the overlying epithelium or the peritoneum of the ovary. However, in most other characteristics, the cell layer of the surface epithelium of the ovary is similar to the cells of the peritoneal cavity otherwise. You must also remember that sometimes the outermost layer of the ovary is called as the germinal epithelial layer of Waldeus. The word germinal epithelium here should not be used and is actually a misnomer, because the primordial follicles are not formed in this outermost layers. Just to clarify, this is a detailed photograph of the ovary. You can see the germinal epithelium which is pointed to the outermost cuboidal cell layer. Actually, this is not giving rise to the germ cells and therefore is a misnomer. Just next or inside the germinal epithelium is the tunica albuginea. Then comes the cortex with its varying stages of folliculogenesis, and the inside is the medullary part. So this is the photograph which is depicting the process of ovulation. You can clearly see the breach which is seen in the surface epithelium with the release of the ovum. Now, this is one of the reasons of the postulation behind multiple ovulations causing an increased predisposition to ovarian epithelial cancers. So basically, the concept here is that each ovulation causes a minute amount of tissue injury at that local site, and because of this tissue injury, such multiple tissue injuries may induce certain DNA mutations and cause the proliferation of a certain mutated DNA carrying cell into an abnormal cell line, in short, an ovarian tumor. Now, all ovarian tumors behave slightly differently from the other genital tumors. That is, the preference for dissemination is not via blood. In fact, in the ovarian tumors, it is the surface spread which is most important, and we can easily see that here because the surface layer of the ovary from which these tumors are probably arising is almost similar in its embryonic origin and histology to the visceral peritoneum. Therefore, the peritoneum is one of the easiest methods of spread of an ovarian cancer. One of the highest number of seedlings are found in the greater omentum, which acts as almost a collecting basin for the mets, and also the most virulent form, which is known as peritoneal carcinomatosis, is one of the features of ovarian cancer. This is an interesting paper which has been presented, and this paper says that the surface epithelial cells of the ovary, as we discussed, are modified peritoneal cells. And in fact, the Mullerian ducts, that is, the ones which give rise to the uterus, are actually formed by the invagination of the coelomic epithelium, which also covers the gonad. So, endometriosis can actually be explained by the coelomic metaplasia from the peritoneum, and this includes the same origin of the ovarian surface epithelium. So much is the importance of the peritoneum in the abdominopelvic pathologies. In fact, we haven't discussed many of the other features and the role of the peritoneum and the mesentery in disease and maintaining health. However, for the purpose of this talk, it suffices here to know that the peritoneum is deeply involved in the origin and pathogenesis of many diseases, and we will discuss more in relation to the mesentery a little later on. So this is yet another slide in which I have pasted an article which discusses the same thing as we discussed some time back on why the ovarian cancers spread preferentially via the peritoneal route. So this is depicting the situation of laparotomy. So when we cut open the abdominal wall, this is how we enter into the abdominal cavity. Yet whatever organ that we are seeing as intraperitoneal, secondary retroperitoneal or retroperitoneal is covered by the peritoneum. Sharing one word about the bladder you can see in its deflated state is partially covered by the peritoneum there, lined in blue, and therefore in its deflated state, it has a peritoneal covering and is known as subperitoneal in location. However, in the filled condition, the bladder rises up and lies against the anterior abdominal wall and pushes the peritoneal cavity behind it. In this condition, it is known as preperitoneal bladder. From the second picture here, you can easily see that the bladder, if it is very distended, comes to lie preperitoneally, and this is one of the commonest causes of bladder injury when a suprapubic port is being placed, sometimes directly when we are performing a lap TL. So you can see that just behind the muscle is the bladder, the peritoneum is pushed behind. This is a list of organs which are totally intraperitoneal, primary retroperitoneal, and also the secondary retroperitoneal organs.